Hello, and welcome to Physician Spotlight, which is a forum to learn more about outstanding senior leaders, young rising stars, and international colleagues in the field of nutrition, and to discuss important topics and ideas. And with the help of Aspen, we are bringing these videos to you today. I'm your host, Dr. Lindsay Russell, and it's my absolute pleasure to introduce our guest today, Dr. Patty Byers. So Dr. Byers is a professor of surgery and serves as the chief of surgical nutrition at the University of Miami Miller School of Medicine. She's had over 35 years of experience in surgical nutrition and intestinal rehabilitation, and is a faculty member in the Division of Trauma and Surgical Critical Care at the Ryder Trauma Center at Jackson Memorial Hospital. She is the immediate past chair of the Aspen Public Policy and Advocacy Committee and is a member of the Aspen Physician Engagement Committee. She also previously served as the chairperson of the American College of Surgeons of Florida Committee on Trauma, and she's the first prior president of the Florida chapter, and has served on the American College of Surgeons Board of Governors as chair of the Grassroots Advocacy Committee as well. Not only that, she's also has multiple publications assessing nutrition following trauma and multidisciplinary surgical team. She's received also numerous awards for her clinical skills and compassion for patient care. And I'm so excited to have Dr. Byers today. Dr. Byers, thank you so much for joining us.
Wow, I don't know who you're talking about. Let me see. Is there someone else here? Thank you so much for the introduction.
Yeah, yes, it's just such an honor. And, I love to first start off, it's quite unique that, you're such an accomplished surgeon. And what was your journey like towards a career that involved nutrition and in surgery?
Well, I always enjoyed critically ill patients and trauma and critical care. And that's where I started my journey. And one of our faculty members was Miguel Echenique. Now, Miguel Echenique is from Puerto Rico, and he had completed a fellowship with Bistrian at the Deaconess. So he actually came down here and started a nutritional support service, and had a dietitian, a pharmacist, and a nurse, and actually was doing like rounds in the ICU with TPN, and actually had some home TPN patients. And the reason he was able to do that is Dr. Zeppa, who was the chair of surgery at the time, was actually knew Stan Dudrick very well. And he was an advocate for nutritional support because of his relationship with Stan. So he encouraged the development of that service. So soon afterwards, as many of the trauma faculty did back then, he went on to get another position, and there was nobody to take care of the patients and the service that he had developed. So when I was hired on at the end of my chief residency, the idea would be that I was going to like have a little preceptorship with him, let's say. So he had about 2 to 3 months to teach me everything he knew. And then the service, then I was in charge of the service. So I had a lot of learning on the job. And back then I was actually involved with Aspen way back then. But anyways, so he actually got me totally involved in taking care of those patients. So I inherited that whole position. And I have to say, I kind of look at the faces on my residents and fellows now, that they are a little overwhelmed when they start taking care of these kind of patients. And I remember back then I felt pretty overwhelmed too. But, if you dive in and you think a little bit and figure it out and you read, you can really do a lot, for these patients. And so then, of course, Dr. Zeppa brought Dr. Dudrick to our hospital center, and he rounded with me. And after that, I knew I was in the right place, because the enthusiasm that he had and the ability to think out of the box, he actually taught me to think out of the box and come up with different kinds of solutions. Which I did in the very beginning, because there wasn't a lot of evidence-based back then. Everything was like just kind of brand new. Because as I was just realizing that in 1977 is when there was that long list of things to do for nutritional assessment. And then it was such a relief when the assessment came out, because then you didn't have to do all those labs. So I've enjoyed that as a career path, and it's been an important career path for me.
Yeah, I just think that's so inspiring. When I do a lot of these interviews, you just hear people who've along their journey have just met someone with so much passion and then just kind of dive in as well as you saying. So that's just so wonderful. On that line, how do you implement like nutrition education in surgical rotations or with trainees? Like as you mentioned yourself, you had other faculty members kind of bring you on and introduce you. How have you done that with your career in this unique, not unique, but with surgery and surgical nutrition?
Okay, well, the reason I coined the term surgical nutrition is, to me, I'm very passionate about the fact that I think it's very, very important that surgeons know and learn about nutrition.
Mhm.
And unfortunately, because of the work hours, surgical education is being compressed. But thank goodness that we have dietitians and pharmacists that are very well educated that can help us. But still, if you don't understand what they're doing, you're not going to make the right surgical decisions, right? And that's why Dr. Dudrick, developed the idea, and it was surgeons that developed the idea of TPN, because it's surgical diseases that create these patients. So the patients that have intestinal failure are either surgical catastrophic cases or they're surgical complications. So if you don't understand nutrition, you're going to have bad surgical outcomes, and then you have to have the surgical skills sometimes to repair these patients. So my practice now is there's a lot of intestinal failure that we do. We do intestinal rehab, but we also do a lot of like Humpty Dumpty type work of patients that have had a lot of surgical mishaps, fistulas, and are, a mess. And you have to have the tools of getting these patients stabilized to be able to reoperate on them again. Otherwise, you're operating on someone with macro and micronutrient deficiencies. And then that doesn't ever work out. You don't make them better at that point. You can actually make them much, much worse. So I'm very passionate about the fact that this is something that surgeons need to know. And it's wonderful to have the collaboration of all the other personnel to help. So right now in our program, we have a nurse practitioner who primarily takes care of the outpatients and their TPNs, a PharmD who's basically runs the pharmacy issues, helps us in the hospital with the consults, and also helps out with the home TPN patients. And we have a dietitian that works with us as well. So that's great. But I didn't think it was enough, and I felt that it was very important. Our service is different than like the usual nutritional support service, because most of those kinds of services, people are rounding in the hospital on the TPN patients in the ICU, or they have are on the floors, and they have some patients with short bowel that get admitted. But our patients are very different. Our service is actually a very busy surgical service, because we get patients transferred in from all over with abdominal catastrophes. The other day, we had someone transferred in with an open abdomen with the surgery not finished. So we had a patient right to surgery. So I felt that I wanted the interns to learn the basics of nutritional support. And so we, on our service, and I've had for 25 years now, interns on this surgical service, where they have to learn how to calculate TPN, learn how to do nutritional assessments, learn how to write tube feedings, what are all the different types of tube feedings, how do you figure out if someone's pre-op malnourished, critically ill, malnourished because of acute illness, how do you treat them? How do you get them to a stable formula to go home? That sort of thing. So I've had translators for years, and it's a very unique rotation. I mean, actually, every time people come to interview for our surgical program, they ask about that service, because other places don't have it. And so 4 years ago, we also started a fellowship, because the cases became very large and very complicated. So we felt it was important to have a fellow on the service. So now we have a surgical fellow who we can actually teach to not only learn the nutritional side of things, but also all the different types of crazy refeeding and the access to do refeeding and all the complicated surgical procedures that need to get done on these patients.
Oh, well, that's so wonderful. I really like that you highlighted that it truly is a multidisciplinary team in managing nutrition, but like the unique aspects of surgical patients, post-trauma patients, or the critically ill, and how that fits all together. And it's very inspiring to share that education for the next your program for the fellows, which is so great. With that being said, do you have any specific, because you're so accomplished in your field and with your experience, do you have any words of wisdom for early career healthcare professionals or researcher that are just starting out in the field of nutrition, whether they're surgical or medical? Any advice you have?
Yeah, well, I think that for research, I think that it's a wide open area. It's an area that's wide open. I mean, you can do clinical research. There's so much metabolic research to be done. I mean, we're just unwinding the genetics of the microbiome and all that right now. So I think that it's a great field if you want to have an academic career, because there's just open doors everywhere. I think that for surgeons, for example, surgeons don't think of it as a career, but I think that it's an area as a physician or surgeon, if you want to get into it, you can get involved in Aspen. That's another area of incredible opportunity to get involved, to help you get promoted, etc. So that's important. But honestly, I think for me, like I really feel I enjoy doing trauma and critical care, but I didn't enjoy the fact that I wasn't really meeting or knowing the people. So the side of my practice where I really I have patients that I followed for 30 years. I have patients that are dying of old age with intestinal failure. So I feel like that's an incredible accomplishment. You know?
Yeah, exactly. That's wonderful.
So I just, I feel that relationship and how, you can actually do something for patients. And these patients are orphans. So they're out there. They can't find anyone to take care of them. And it's like you spend the first, I don't know, 5-10 interactions with the patients to get them to trust you because they've been, just had a run around all this time with this horrible illness. So I think the satisfaction of the patient care is also really, really tremendous.
I think that's so wonderful. And yeah, I agree with you that nutrition doesn't necessarily go away, right? Especially in short gut or intestinal failure patients. It's really a long journey that you take on with patients together. And just the last question, anything, outside of medicine and nutrition, I know our audience would just love to hear any fun facts or interesting caveats about yourself that you could share with us.
Okay, well, there's two interesting things. I told you one earlier. So
Yeah.
I had a gap because it was I went to college in Connecticut and I grew up in Connecticut and I didn't want to stay in Connecticut. And I was really angry with my parents for telling me I had to go to a state school because they didn't want to pay for a private school. So after I got straight A's in the honors program, I dropped out of college and went to work in a lipstick factory. And then I saved up a bunch of money so I could come down to Miami, basically. And so the other thing that gave me a 6-month gap. So then when I was applying to med school, I had another break. And during that period of time, I actually went to work in an explosives factory as a chemist.
Oh my gosh, I can only imagine.
Yeah, so that was interesting. You had like all the buildings were made in case there were an explosion, the roof would blow off and it wouldn't hurt the surrounding community. There were cement blocks with tin roofs, all the buildings that we worked in. It was a little bit intimidating after me.
I can imagine that kind of may have been a foreshadowing for TPN of, mixing the compounds together and
Yeah, because I was a chemist, I was working with a PhD. We were trying to invent stuff, like safety things for electrical wiring and things like that. So it was it was good. It was fun.
That's wonderful. Well, Dr. Byers, thank you so much for joining us today. And thank you to Aspen for their partnership to continue with this program and our audience for tuning in and taking the time to listening and watching. Have a great day, everyone.
Lindsay, thank you so much for such a nice interview.